Okay, so this other part of the chapter, the blood chapter, uh, starts with the process of hemostasis. Hemostasis is a process that is vital because it stops bleeding when we have an injury, and it requires the activation of coagulation factors that are produced by the liver, and it takes a series of steps. We have cascades of coagulation that is part of the coagulation step. That's a little bit more complex than the rest of the other steps, but it's not necessary for you to know all the details of the coagulation process. However, know that we have this series of steps that leads to prevention of bleeding when someone has an injury. So we have, in this case, 5 steps for hemostasis. The first one is called vascular spasm. When someone injures a blood vessel, this blood vessel, since it has in its surrounding areas in the wall, it will have, not in the surrounding areas, in the wall, it will have smooth muscle cells. These smooth muscle cells will respond by contracting. This is known as vascular spasm or vasoconstriction. So what you're trying to do here, after you injure a blood vessel, is through this vasoconstriction to reduce the blood flow so that you have less amount of blood going through this blood vessel. Now, after this, the next step is forming a platelet plug. Platelets are fragments of cells that comes from the megakaryocyte, which is a gigantic cell that is found in the bone marrow, and this releases cytoplasm, which is the platelets, and the platelets have in part they have calcium, they have ADP and all other molecules that can help them to become activated once they find an area where it needs repairing. So in this case, this is a magnification of this area of an injured blood vessel, and this is the longitudinal section of this blood vessel, so you will be able to see these endothelial cells, and this is part of the background of the wall. And here, where you have the injury, where these endothelial cells were damaged, you will have exposure of collagen, and as well of a factor, it's called Bonds-Willebrand factor. So this Bonds-Willebrand factor that is produced when someone has an injury, and we're talking about normal hemostasis, there are actually people who cannot produce that factor because of genetics, and they have a type of hemophilia. But then once you release this Bonds-Willebrand factor, that is going to activate your platelets. So your platelets become activated, and part of this activation will be to expand. So from little fragments, they start becoming enlarged, and then these platelets start adhering into the area of injury because they become attracted to these exposed collagen fibers. And they will form something that is called a platelet plug. It's going to be a temporary solution, and you will initiate a positive feedback after you form your platelet plug. So these platelets are going to release granules from their cytoplasm with the contents like ADP, calcium, that is going to activate and attract more platelets. So this small clot becomes a little bit larger. And this is a temporary solution. So the next step is going to coagulate. So basically to affirm this area where you have this temporary platelet plug. And the way to do that is by activate the coagulation factors that we have in our bloodstream that are inactive, and also add some molecules like calcium is one of the coagulation factors, so that you can strengthen this clotting. So, coagulation includes two major pathways, intrinsic and extrinsic, and a common pathway. So, the extrinsic pathway forms when you have tissue injury, and then you activate particular factors like 3 and 7. For the intrinsic pathway, it will be factors. We have like 13 coagulation factors. So in this case will be factors 8, factor 9, factor 11, and factor 12. No matter if you activate intrinsic or extrinsic pathway, they in common activate factor 10. And then factor 10 is going to start the common pathway that starts with thrombin and finalizes with the formation of fibrin. Fibrin forms from a precursor that we know as fibrinogen, and this fibrinogen is a series of little strands that become a large strand once it becomes activated. Since we are not bleeding all the time, these coagulation factors are normally inactive. It only gets activated when you start these pathways. So here is what happens with this intrinsic pathway or contact activation pathway. So you have a tissue injury, and then you have these exposed collagen fibers, you have your platelet plug, and then these exposed collagen fibers going to attract this factor 12 that is inactive. Anytime in coagulation where you see only this Roman numeral, which represents in this case 12, but without a suffix that is A, in this case here, that means that this is inactive. So factor 12 is inactive, then comes in contact with these collagen fibers and these platelets and become active. So then it will be 12A. After this, factor 12A, which is going to be an enzyme, is going to be a serine protease, is going to be capable of activating the next coagulation factor, which is going to be 11. So 11 now is going to become 11A. And then 11A is going to be the enzyme that activates factor 9. So 9 that it was inactive now becomes active. So then goes from 12, 11, and 9. And then lastly, as part of entering into the common pathway is the formation of active factor 10 when factor 9 that now, since it becomes active, joins this enzyme complex plus calcium. Calcium, again, is one of these coagulation factors. So then you will activate factor 10 to become factor 10A, and then you start the common pathway, thrombin and then fibrin. So many people may have problems of coagulation. They might not have enough platelets. The quantity of the platelets will be altered. The Von-Willebrand factor might not be formed. The quality of the platelets might be affected, or any of these things in the coagulation cascade can go wrong, including the lack of certain factors. But many people don't think about calcium. Hypocalcemia can lead to poor hemostasis. So we have seen calcium everywhere since AAP1. We've seen it in bones. We've seen it in the in the cartilage, everywhere. In the, sorry, not in the cartilage, in the neurotransmission. So it's also part of the hemostasis cascade, and we will see it again in urinary system, digestive system, reproductive system. Remember, even calcium is necessary for olfaction, taste. So it's one of the major ions that we have in our body. And now, once you have this cascade going on, then you have the tissue factor pathway, in which basically you have this tissue factor that is exposed after an injury that will lead to activation of factor 7. Factor 7, so this one, sorry, was the intrinsic pathway. The extrinsic pathway starts when you have an injury, you expose this tissue factor, and then you form a platelet plug, and then you will have activation of this factor 7 into factor 7A, and then this factor 7A, since it's going to be a serine protease, now can activate this factor 10 into 10A, and then plus calcium, you will form an enzyme complex with calcium, and that will lead to the common pathway. That no matter if it's intrinsic or extrinsic, you have in common activation of factor 10 that now is going to lead to the formation of thrombin. Thrombin, it comes from a precursor just like a fibrinogen, form fibrin. Now it comes from a precursor, it's called prothrombin. So prothrombin is inactive and now becomes activated with this prothrombin factor, which is factors 10 and 5A in calcium. And then this is called prothrombin activator, all this complex. So then when you have thrombin, thrombin now can activate fibrinogen. And fibrinogen will become fibrin. So then this fibrin, which was inactive before, will coat all of these clot, and then it will strengthen this clot. Why? Well, because you still have blood circulation. If you only leave the platelet plug and then you don't put this fibrin, these erythrocytes, these leukocytes can really easily be swept away. So that's basically setting the clot by making it stronger with this fibrin. So I compare this to when you have a broken window in your car. Well, what are you going to do if it's raining, if it's windy, and it's during the weekend at night when you have a broken window in your car, or if it's snowing? You have a plastic bag, you put it there, right? But what if you just put the plastic bag, but you don't put tape around? So then you start driving, and that plastic bag, if you don't put the tape, it's going to go out. So fibrin is the tape that keeps that plastic, that keeps that platelet plug. So that when you have a physical force, it doesn't sweep away the platelets. So in this case, it will be the blood flow. For you driving will be the wind. So that was Sunday night, a crook broke into your car, and then you start doing this temporary solution. Now, the next step will be clot retraction. So you will have loss of water, serum in this place, and then that will help for the edges of these endothelial cells and the basement membrane come close together, and that will make this to be smaller, so that's why it retracts, and that helps for sealing better the area. So, of course, when you were repairing your broken window, temporarily repairing, putting the plastic bag and the tape around to keep it in place, you don't leave a lot of plastic bag out. So you just start stretching it till it's stretched enough to cover the entire window without protruding a lot. So that's clothing retraction. Now the next step will be thrombolysis. So then you finalize sealing this blood vessel, so you heal the wound. There is no more need to have the blood clot there. So in this case, you activate plasminogen. So your cells will release TPA, tissue plasminogen activator. Tissue plasminogen activator is going to activate plasminogen, which is inactive, to become plasmin. And plasmin is going to start to dissolve this blood clot of fibrin. So it's an antagonist of fibrin. So that's thrombolysis. Why will our body keeps the blood clot there if you already repaired the area that it was unsealed, the injury, the opening, the gap in your blood vessel? Is there a purpose to keep it there forever? Oh, what a beautiful blood clot I formed. I will keep it there to show off. No, you won't do that. If you keep it there for a long time after it's sealed, the blood vessel, you are reducing blood supply to other tissues, so there is no purpose. So then Monday morning, you go all mad to that crook that broke your window. You go to the repair shop, they put a new window in your car. Would you keep that bag there and the tape to show people, oh, I know how to temporarily repair broken windows in my car? No, you take it out. It'll be so crazy. So similarly, we don't keep the clot there forever. Okay? So then, there is actually a use for this for certain cases, clinical cases, for certain drugs, tissue plasminogen activators. If someone has myocardial infarction, so it had like an occlusion right in the coronary. Let me put it there. In one of the branches of the coronaries or the coronary artery. So if you make a cross section of this blood vessel, and this is the lumen, so this is the coronary, and then you have here plaque. So let's say that you have it 60% occluded. And the person still, I don't remember this. Hopefully that's right. So, of course, the person is going to have hypoxia in the heart, and the person is going to have pain, angina. But what if a fragment of blood clot is formed in the body, migrates, this is called an embolus, comes and occludes this area, the other 40%. So this is an embolus. What is going to happen to the tissue that it was supplied by this coronary? Is it going to be healthy or is it going to die? It's going to die, right? That is going to cause a myocardial infarction. So there are some drugs, the tissue plasminogen activators, that can be given to the patient, and that is going to start dissolving this. so that the person can have the blood supply happening, and as well they insert a balloon, this is called angioplasty, and they start breaking this. So tissue plasminogen activators can get rid of occlusions where they are not needed. Now, not everyone is candidate for that. If someone has problems of coagulation, you cannot give this. And similar for streptokinase enzyme.
If you're given TPA to break up on an inclusion, are you going to have issues clotting like a normal bleed? Like if you just
No, because I mean they give you the proper dose, and that it's eliminated as well. Okay, very good question. So then, again, you go through all of these steps to repair an injury in a blood vessel, but once you're done, there is no more need of those anymore, so then you end up with thrombolysis. That's the purpose. And now here we have the names of all of these factors, what they do, and the description. So fibrinogen is factor 1. And just as all the coagulation factors, of course, exception of calcium, but basically they are made in the liver and also in platelets. Calcium is factor 4. And then we have Hageman's factor, factor 12. And then here we have factor 10, Schwartz factor, factor 9, Christmas. And it's because of the last name of the person who discovers it. So we have all of these factors, their names. I mean, you don't need to know any of these, but people, it's aware of all of these, of course, more when they have a problem in the family. They might know someone who has hemophilia, person has an injury, bleeds really easily, and all that. So anyway, and then here are the thrombolytic agents. So we have TPA, that it is made by the endothelial cells. We have other ones like antithrombin 3, prostacyclin, that is made by endothelial cells. Heparan sulfate, that it is produced by many different cells, blood cells including. And these are antagonistic of this antithrombin, which binds and inhibits thrombin factor and factor 10. Protein C, that is also produced in the liver, and its synthesis requires vitamin K. So vitamin K, it's also part of these agents or regulators of clot formation that is necessary. Like, for instance, protein C is needed for degrading factors 5 and 8A. So when they are active, they also need to be recycled, and protein C is one of these that helps us to do that. Okay, any questions about coagulation and hemostasis? Okay, now hemopoiesis, term similar, but in this case is forming blood cells. So in hemopoiesis, we have a precursor cell, which is called the hematopoietic stem cell, that is located in the bone marrow. So just as any stem cells in the body is capable of producing other cells, and these cells are less differentiated, but more than this one, and through these cells, which in this case will be cell lines, for this specifically will be myeloid cell line, this can give rise to different other cells. So, hematopoietic stem cell can subdivide into lymphoid cell line cell and myeloid cell line cell. This myeloid cell line cell is going to give you an erythroblast or proerythroblast that is going to become an erythrocyte. It can give you a megakaryoblast that is going to give you a megakaryocyte that is going to become a platelet. Or it can give you a myeloblast that is going to become a myelocyte that it can become a neutrophil or a eosinophil. So let's follow this pathway. So this, it's a proerythroblast. And this proerythroblast will become an early erythroblast. And then as the process from proerythroblast to late erythroblast and early erythroblast happens, you will have more production of hemoglobin and the reduction in the size of this nucleus because the nucleus is not needed anymore, and then it is occupying a space, so you just create hemoglobin, put it in the cytoplasm, and in late proerythroblast, you eject the nucleus, and then you form a reticulocyte or a young red blood cell, and you form a mature red blood cell. This process takes around 7 days to happen. Now, for the megakaryoblast, you will form a megakaryocyte, and this megakaryocyte remains attached into this bone marrow, and you will start releasing platelets. The number of platelets that we typically have is between 150,000 and 450,000 per microliter of blood. And then in the case of the red blood cells, depending on the gender is how many you expect to have. Like in males is between 4.5 to 5.8 millions of cells. In females is between 3.7 to 5.2 millions of cells per microliter of blood. For neutrophils, they come from a promyelocyte, and when they're young, they're called band cells, neutrophils, and they have granules, and they have this segmented nucleus. Another name for these cells is called polymorphonuclear cells, or PMNs, because this nucleus can take many shapes. And then they make 40% of the total leukocytes. And we have a total between 4,500 to 7,500 cells per microliter blood. These are in charge of taking care of bacterial infections mainly. So when someone has a bacterial infection, these numbers increase. So you will have neutrophilia. When you have low blood counts of neutrophils, this is called neutropenia. And then you have more chances of having infections with neutropenia. For eosinophils, it comes from the same precursor as the neutrophil, from a promyelocyte. And the young form of eosinophil is going to be an eosinophil band. So it has kind of a horseshoe-shaped nucleus, and the granules that they have, they stain red in color. So this cell, it's a granulocyte, and it looks reddish. And you have fewer than 3% of total leukocytes. They make like around 40 to 450 cells per microliter of blood. And these eosinophils, they increase in numbers when someone has a parasitic infection or when someone has an allergy. The granules, they have enzymes that can kill parasites, and also has molecules like histamine and heparin. And histamine, it's a chemical mediator of inflammation, so it can trigger inflammation. No questions.
Is that the last slide you just had? Is that what a TBC is? A total blood count? Is that what they're looking for?
Yeah, you give the percentages. And then for basophils, they are precursors from myelocytes, and similarly, the young form is called band cell basophil. Basophils, the nucleus is large, but it's obscured by a multiple, by very abundant granules. They look purple, so you hardly see the nucleus. You see a lot of granules. And these ones, they also have chemical mediators of inflammation. This is the less abundant cell, the white blood cells. It makes less than 1% total, between 0 to 200 per microliter of blood. So then for not megakaryocytes, for macrophages, they are precursors of the promyelocyte, and the next cell in the lineage is going to be a monoblast. Monoblast is a gigantic cell that becomes more bigger, so it's going to form a promonocyte, and then they form a monocyte. As it matures from monoblast into monocyte, this undefined shaped nucleus become like a horseshoe shape. And monocytes, they will be called monocytes when they are inside the blood vessels, but when they exit the blood vessels, it's going to be called a macrophage. And this is a granulocyte, so it doesn't have granules. And this one, it makes between 4 to 5% of the total leukocytes, which is between 0 to 800 cells per microliter. These ones are in charge of eating up debris, bacteria, when they are outside of these blood vessels. Monocytosis is indicative of either bacterial infection with chronicity, so a chronic infection, or maybe a viral infection. Now, coming from a lymphoblast, from the lymphoid lineage, we have these these prolymphocytes. So you have a myeloid line and a lymphoid line. So the lymphoid line only gives you lymphocytes. So this is the lymphoid cell line cell that is going to give you a lymphoblast, and then it gives you a prolymphocyte. The nucleus is always large, and the cytoplasm is always very little. Now, morphologically, in the light microscopy view, and even sometimes in electron microscopy, it's hard to differentiate when it's a B or T cell, or it's impossible. Now, then you will have molecular markers that can differentiate when it's a T lymphocyte and when it's a B lymphocyte, and then when it's a subtype of these lymphocytes, especially the T cell line. So this prolymphocyte can form T cells and B cells. T cells will exit the bone marrow and mature in the thymus, while B cells stay in the bone marrow and mature in the bone marrow. So B lymphocytes become active when they encounter an antigen, which is a foreign molecule or something that the body considers foreign, and then they start secreting antibodies. And when they secrete antibodies, they are going to be called the plasma cells. And then the reticulum endoplasmic enlarges, and the nucleus becomes smaller. And then they can form, both of them, memory cells. Now, T cells are cytotoxic in one type, and they can destroy virally infected cells or cells that have infection. They make between 30 to 40% of the total leukocytes, and that's between 1,000 to 4,500 cells per microliter of blood. Percentages reported in your total blood count varies, the more abundant cell is the lymphocytes. And they will give you the labs, they give you the average and the range of the different cells. So in a way, depending on which lab you're talking about, is what normal numbers they provide you, and of course the numbers that the patient has. However, there is this mnemonic that it can help you to think about the order of abundance of these cells. So we have never let monkeys eat bananas. So that means that the most abundant, so more to less. So it would be neutrophils. Sorry, I said before the lymphocytes are the most abundant. No, it's neutrophils first. So neutrophils, then lymphocytes, then monocytes, eosinophils, and basophils. Basophils form less than 1%. This one more or less like 50%, 40%, and then the other percentages to make 100. Like 4 to 6 for the monocytes. Any questions? Okay, so now let's move into blood types. So the erythrocytes have antigens in the plasma membrane. And these antigens are used to classify the blood into major subtypes. So we have the ABO classification, and then we have the RH classification that always it is combined with the ABO, so that you can either have ABO positive types or ABO negative types. If you don't have the RH antigen, you will have RH negative type of blood. If you have the RH antigen, that would be positive type blood. So here we have an example of type A blood. So this is the erythrocyte, and this will be the antigens, A antigens. And of course, this is an illustration. It doesn't exist in that shape, or they have the letter A. But it's just to illustrate that we have antigens that makes this blood to be A. Then we have B blood type with B antigens. And then we have a combination in which you can have both A and B antigens, and then the blood type will be AB. Or you might not have antigens, A or B, then you will have type O. So based on ABO, you can have A, B, AB, or O. 4. Now, if you combine the RH, which is D antigen, that will be 8 different types. A positive, A negative, B positive, B negative, AB positive, AB negative, O positive, and O negative. So those are the 4 major blood types that humans have.
So So the negative means the antigen isn't present?
Isn't present, and that will be the D antigen, which is also known as RH. RH is for the first time, or from the species of monkeys where they discovered this antigen, which is a rhesus monkey. And then, again, everyone has one of these type of bloods. A, positive or negative. B, positive or negative. AB, positive or negative. O positive or O negative, based on these major antigens. But each of us, guys, have at least 500 more antigens as a minimum in our blood cells, in the red blood cells, that are unique, that no one else have. And that's why when someone has blood transfusions that are frequent, and then once in a while they encounter that apparently their correct type created a blood transfusion reaction, which is not fun at all, it's severe, then you know why. Because these other antigens that are found in the donor, that are not found in the recipient, can make the recipient's immune system to react to this. And then you have a blood transfusion reaction. It is said that the best blood transfusion that someone can receive is the one that you don't receive, because of the chances of mismatching. Plus, also, no matter if you have match, you are receiving tissue from someone else. Remember, blood is tissue from, it's the only connective tissue, fluid tissue that we have in our body, so it's a tissue. So you are receiving a transplant, basically. And that immunosuppress you, which leads to longer stays in the hospital, some complications, not counting that if the blood wasn't properly screened, someone can get an infectious agent through this blood transfusion. So here we have the classification as positive or negative. So in this case, we have O negative because you don't have this Rh or D antigen, and this is O positive. Now, among these 8 different groups of blood that we have 2 that we can subclassify based on the fact that they can either give blood to all type of blood or receive blood from every type of blood. If they give blood to all kinds of blood, that will be universal donor. If it receives blood from every kind, if it can receive blood from any kind of blood, that will be universal recipient. So then we have them in here. So here we have AB negative. So this AB negative doesn't have antibodies against A blood type, against B type, or against O, or against RH. So this will be universal recipient. It can receive from A, actually, wait. Will be have to be positive. Yes, it's backwards. So let me explain then I can clear my thoughts as well. Have the black marker. Oh, here it is. So antibodies are proteins that can block antigens, and they can attack cells. Okay? So antibodies, they have a Y shape. Here is where they can bind in the tip of these arms, that's where they can bind the antigens. Now, if you have an erythrocyte with, let's say, how they put 8 antigens with a circle. So in this ending of this arm, which is called the antibody binding region, you're supposed to have a shape that corresponds to this antigen. In this case, it's semicircular to bind this sphere. So let's say this is A blood. So this is A blood. And this antibody is anti-A antibody. So this one can fit into here. If someone has A blood type, it cannot attack its own blood. So it cannot have this type of antibodies. But the person can have anti-B antibodies, which in this case will look like a triangle, the ending, the antibody binding region, to bind B antibodies. So if you have a triangle like this, it can be bound by these anti-B antibodies. So if this is B, this is B blood. So this one can attack this blood, and this can attack this blood. Sorry, this can attack this blood, this can attack this blood. If you have B blood, you cannot have anti-B antibodies, but you can have anti-A. And if you have A blood, you can have these antibodies, but not this. Have a dog, it's supposed to bite you, right? Maybe another one, and even if you bother that dog, it can bite you. And even your own, but don't put it that way. So then, someone with A blood can have anti-B antibodies, and someone with B blood can have anti-A antibodies. Now, in the case of the universal recipient, which will be AB positive, that's wrong in there, IB positive, it will have this, so you will have B, and then it will have RH. So the person won't have this type of antibodies, don't have this type of antibodies, nor will have this type of antibodies. So what it means is that since the person doesn't have this, or this, it can receive A blood type, B blood type, AB blood, no matter if it's positive or negative. So that's that universal recipient. Now, the universal donor, which will be O negative, that's wrong again. In this case, you will have an erythrocyte that it doesn't have A antigens, it doesn't have B antigen, and it doesn't have RH. So this is O negative, you write it like that, O negative blood. So this person at least will have anti-A and anti-B antibodies for a minimum. So this person cannot receive blood that has A, B, AB, or RH, because it will have anti-A, anti-B antibodies. But why RH not? Well, first time, if it receives like O positive instead of O negative, it kind of creates a reaction but delayed, because the person will start forming anti-RH antibodies. But the next time, it will have these antibodies formed out of memory, and then the person can reject right away the blood transfusion with a positive type. But since it doesn't have these major antigens, so it doesn't have A, B, or RH as you see it there, it can donate potentially to any kind. It can donate to O, positive or negative. It can donate to A, positive or negative. It can donate to B, positive or negative. And it can donate to AB, positive and negative. So that's why this one will be universal donor, while AB positive will be the universal recipient. So this one can have the 3 antibodies, and AB positive will not have none of these antibodies. So universal donor, universal recipient.
Is it pretty rare?
Yes. And RH negative in general is rarer than positive.
What about AB negative RH factor? We can't get anyone's?
The RH factor is negative itself, so it doesn't have RH, it doesn't have the D.
That's what my blood card says. So I don't have any of those? I don't have any?
So you are AB negative, so you are this type.
Okay, take it.
But you cannot receive AB positive or any positive type. Negative, guys, negative type never, ever, no matter if it matches the ABO, cannot receive positive. Positive can receive negative, negative cannot receive positive.
So you better make sure the blood you get is green.
Don't wait on.
Yeah.
And it's rare. It's only 15% of the population here that is Rh negative. So then that one is backwards, right? So then this is what happens when you have this type of reactions, agglutination reactions. So basically, if you have these erythrocytes with A antigen, and then you combine them with anti-A antibodies, these anti-A antibodies, which by the way are pentamers of IgM, you can clump all these erythrocytes, and these will undergo hemolysis in the blood, in our body. So this is like the basis for actually testing for what type of blood you have. You use antibodies, and then you put your sample of blood, you mix them together, and if you see a clump in the reaction, that means that you are that blood type. And if you don't see that reaction, you're not that blood type, as easily as that.
Does that work with organs too? Like giving and receiving organs?
Yeah, it can happen. So we will see a little bit of that in the lymphatic system for transplant and all that. But in essence, anytime that someone is going to receive an organ that is a bloody organ, of course, if it's the skin, I mean, you don't have that problem. But you're supposed to rinse all the blood. Why? Because you're getting rid of the lymphocytes and any antigens that this organ has that is not Of course, the tissue itself has antigens, but it's supposed to be compatible with you. But if you, by accident, leave some lymphocytes there from the donor, and they start growing, they start saying, well, I'm not in my regular body, and they start growing, making a clone, and then you have what is called graft versus host disease, in which the organ rejects you because you are the owner. But again, we will see that later. And now, guys, in general, let me tell you, I know that you have interesting questions, but some of these questions require like better answers or more extended answers. We have plenty of time in the lab. So sometimes if I don't answer you right away, that means that you have to wait until we meet in the lab. But I love these questions because those are the questions that make you think, and then they are interesting itself. I mean, it's good to learn. So here is then an example of typing of blood, just for ABO. So here we have A type, B, AB, and O in that row. And then here in the columns, in this, you have a reaction with anti-A antibodies and a reaction with anti-B antibodies. So you always put a drop of blood in each of these, and then you add the antibodies, mix them, and then wait to see if you have clumping or not. Like in this case, this clumping or agglutination for this, it happens with anti-A antibodies, but not with anti-B. So that means that this blood type is A. And then when you have clumping on B, but not on A, that means that it's B. When you have clumping on both, that will be AB. And then when you have no clumping, that's O. And then you're supposed to have here a third column with the anti-D antibody that tells you whether it's positive or negative. So let's say for this row, for A, if you have clumping with anti-D in here, what blood type will be? A what? Positive or negative? If positive. And if you didn't have clumping, negative. For B, let's say that you have clumping in here with the D, like if you have another column. So that will be B positive. And if you didn't have, be negative. And then if you have the 3 clumps, here will be AB positive. And then yours will be without the clumping. So that will be AB negative. 2 clumps here and no clumping here. And then if you don't have clump in A, B, or D, what type of blood will be? Huh? O what? Oh la la. Oh my gosh. No clumping in the 3 will be O negative. And most of us, we have only clumping here. So because most of us are O positive. That's the most common type of blood. So this table, I wish that I could have done it better, but well, you can see it in your electronic device and in your book. But basically it tells you percentages of blood types that there is, the type of antibodies that people have, and then who the person may receive blood from, who may it donate to. Let's go by prevalence in US population. AB positive, 3%. AB negative, 1%. Yoo-hoo! You're unique. Oh, no, you're not. Humble. A positive, 34%. A negative, 6. B positive, 9. B negative, 2%. O positive, 38. O negative, 7. So the rarest will be then AB negative, O negative, and then AB positive. And then again, look, AB negative, positive doesn't have antibodies. O negative has all the three, anti-A, anti-B, and anti-RH. So this one, that's why it's called a universal donor, because it doesn't have the antigens, it can donate to everyone. And only can receive from O negative. So there's a trait there. And then in here, this one can receive from everyone and may donate to AB positive. May receive from AB positive. Any questions about this? So these blood types are inherited, and they follow a recessive pattern and codominant in the case of AB. So then for the type matching reaction, so you will have, in this case, donor type O negative, so it doesn't have A, B, or Rh antigens, as we saw before. And then here, you have a recipient, which has all the three antibodies, so this is AB positive. So in this case, this universal donor can give to the universal recipient. So you don't have agglutination because this universal recipient doesn't have antigens against A, B, or Rh, which you still don't have here. So there won't be, still in any case, you don't have any agglutination, right? But then in a blood mismatch reaction, so now let's say that this recipient the one that was the type AB positive now becomes the donor. So it's AB positive because he has A, B, and Rh. And then the recipient is an O negative. So this O negative has antibodies, anti-A, anti-B, and anti-Rh. So then these antibodies are going to clump the AB positive type. Even in the case where you have, instead of, let's say, an AB positive, let's say that it was only O positive, that you don't have these antigens. The fact that you have the Rh, that makes it a mismatch. No matter if it's matching the ABO classification, that's a must, guys. Someone who has negative blood type cannot receive positive. But positive can receive negative, like A positive can receive A negative, but A negative cannot receive A positive. Why? Because you have these antibodies. I drew them here, anti-Rh. So there is a specificity for the antibodies. So B only binds to B antigens, B antibodies against B antigens, and A against A antigens. So if you put B blood type with B antibodies, you have agglutination. But if you put B blood type and then you have anti-A or anti-Rh, you don't have any clumping. So that's what we saw before in this table, a specificity. So we have this medical condition that is called hemolytic disease of the newborn, or erythroblastosis fetalis. So most of the times, mismatch transfusions doesn't happen. But there is kind of a natural effect when a female who's having Rh negative is pregnant with a fetus whose blood is positive type. So in this case, female with the first pregnancy with it's Rh negative, the female, and that the baby's blood, first baby's blood is positive type, there is not going to be so much effect in terms of the female rejecting or destroying the blood from the baby. When a baby borns, part of the blood from the bloodstream of the baby can go into the mother's blood. That's how it goes. Now, if the female didn't have before any pregnancy with an Rh positive baby, and the baby has born and has transferred part of the blood into her body, she will start developing antibodies that will attack a subsequent type of blood that is positive in subsequent pregnancies. So then these antibodies, which are called anti-Rh antibodies, will play little risk for the first pregnancy. However, in subsequent pregnancies, the baby's blood can be destroyed. That really makes the formation of bilirubin, and that bilirubin goes into the nervous system, and it's going to cause what is called kernicterus, and the baby will die. Remedy here, first, if it's a female who's Rh negative wants to become pregnant, hopefully she will find a mate that is Rh negative. So that way, the chances of having Rh positive baby, it is null. Because actually Rh positive is a dominant trait. So if the male is Rh positive in his blood, the baby is going to have Rh positive. So that's a recessive trait, then Rh negative. But in terms that if you have a dominant, then you will have an Rh positive baby. Now, that's one remedy. The second remedy is, okay, well, she wants to get pregnant, but she doesn't find a mate that is Rh positive. In that case, she can receive a shot of antibodies against her antibodies that is called RhoGAM. And that will prevent that from happening, from her to develop these antibodies, or these antibodies are going to get blocked. So you would have then a shot of RhoGAM that can block these antibodies. And these type of antibodies that can destroy the baby's blood are IgG. We will see in the lymphatic system the classes of antibodies. But basically, these antibodies can cross the placenta. Even before the baby borns, then these antibodies can destroy the baby's blood. So then that's a natural case of rejection or mismatch. Oh, and here we have a better view of all of these percentages. Then see, negative types are always less abundant than the counterparts for positive type. And yes, there can be some ABO also mismatching as well between the mother and the fetus. It's less rare, but the most common type is like a female who's Rh negative can have problems when he receives either a blood transfusion, or if it's a female, get a pregnancy with an Rh positive. So anti-Rh antibodies are only present if an Rh negative individual has prior exposure to Rh antigens. Any questions? Okay, now let's talk about some problems with blood. So anemia. Anemia basically is decreased delivery of oxygen due to poor capacity of the blood, which most of the time can be related to decreased red blood cell numbers, but also deficiency in nutrients like, for instance, iron. And someone who has anemia will have pallor in their skin, in the gums, and the nail beds. Even in the palpebrae, like they can retract the eyelids and you can see it's pale, the color. The person, since it doesn't have a lot of oxygen, it won't generate as much ATP in the mitochondria. So the person will be weak, you will have fatigue, shortness of breath, you will have constant headaches. So that person can have increased number of reticulocytes if the bone marrow is trying to compensate by producing more red blood cells. So instead of having 1% or less than 1% of reticulocytes, the person will have increased numbers if you don't have enough red blood cells. Now, another sign that the person can have, it will be increased heart rate because the heart may pump more rapidly in order to deliver more oxygen. And that can lead to problems later on. The person can even have poor oxygenation to certain tissues that the person can even die of anemia. And then we have different causes, including decreased hemoglobin levels, decreased hematocrit, and abnormal hemoglobin, as we saw before in sickle cell anemia. Another type of cause will be, for instance, when someone has a hemorrhage, in this case is loss of volume. And here is the classification of the types of anemia. So what I told you before, someone may have a hemorrhage, blood loss. That can be due to an injury, a major physical injury, or it can be simple as bleeding from the gastrointestinal tract. Like, let's say someone has an ulcer. The person can have microbleeding if it's not a big ulcer, and the person will be having pallor. So that's an example. I know. We will see the rest next time.